Okay, so many students seeing this question will probably think this is initially too easy, that this is just herpetic whitlow. This is the diagnosis, okay? Herpetic whitlow, Whitlow. This is literally herpes, HSV 1 or 2, of the finger, okay? And it's classically seen in dental workers, like dental hygienists, okay? And it's inoculated from herpes labialis. A patient who's not in healthcare, who's not in dental care, can self-inoculate uh, or auto-infect just by touching his or her herpes labialis, the oral herpes. You can also see this in babies if they're touching the mom's cold sore. So nevertheless, this is a high yield / easy spot diagnosis on USMLE. And then classically what they'll do, like e.g. family medicine questions for 2CK, they'll give you this image, then the answer is just boom, acyclovir. Once again, pretty easy because acyclovir is how we treat. If they ever ask you about route, it's going to be oral acyclovir. Always choose oral acyclovir on USMLE for herpetic whitlow, herpes labialis, or genital herpes, okay? Even if in real life you give the patient topical and oral, on USMLE you're going to choose oral. IV acyclovir, very fucking rare. I've seen it once as an answer, and it was for shingles, which is VZV, not herpes. Varicella, also, so shingles is also known as herpes zoster. Okay, I don't want to get too tangential, but herpes zoster is not a virus. Herpes zoster is just another name for shingles, and shingles / herpes zoster is caused by varicella. Okay, not HSV 1 or 2. Varicella is actually HHV3, which is in the same viral family though, and you treat that with acyclovir. But you can give IV acyclovir if the patient's immunocompromised, such as on chemotherapy or has HIV. Going back to this question, the answer here is going to be altered or absent thymidine kinase. So acyclovir used to treat herpes as a DNA polymerase inhibitor. The herpes viridae are DNA viruses, and acyclovir is going to be first monophosphorylated by viral thymidine kinase, and then the host machinery, the host cellular machinery, will continue to phosphorylate it up to the triphosphate form, which at that point it acts as a chain terminator. Okay, it causes quote unquote chain termination, and it acts as a DNA polymerase inhibitor, as I mentioned. So if there is an altered or absent thymidine kinase, then acyclovir cannot undergo that initial monophosphorylation, and ultimately it's not going to make it up to the triphosphate form and cause DNA polymerase inhibition. So this is the mechanism, altered or absent thymidine kinase, via which herpes, HSV 1 and 2, can become resistant to acyclovir. Likewise, we treat CMV with ganciclovir. It's the same answer, okay? If CMV becomes resistant to ganciclovir, answer, altered or absent thymidine kinase. Now, if the USMLE asks why you can't use acyclovir to treat CMV, or likewise, why you can't use ganciclovir to treat HSV, it's because of different viral thymidine kinases have differing affinities for the drugs. Okay, so the answer would be differing affinity of thymidine kinase for the drug, an answer along those lines. A lot of talking points here. Now, just looking at some of the other answers, altered efflux influx is an accepted answer for bacterial resistance to tetracycline antibiotics. I've read that somewhere. Looking at choices B and D, so altered penicillin binding protein versus beta-lactamase production, extremely high yield when we're talking about staphylococcal resistance mechanisms. So this is where people are going to get fucked. Okay, I'll have to make another question on this, but just because it's so high yield. But when you have community staph, MSSA, methicillin sensitive staph aureus, not MRSA, okay, MSSA, and you give penicillin, let's say, to treat one of those infections, it's not going to work. And the reason is because 90% of community staph, MSSA, produce beta-lactamase. So amoxicillin, penicillin, they don't work against MSSA. That's why you could give amoxicillin clavulanate, that's augmentin. You can give augmentin, that could cover staph because you give the clavulanic acid, the clavulanate, which is a beta-lactamase inhibitor. but you can't give penicillin or amoxicillin standalone to treat community staph because of beta lactamase production. Now, why did I say students are going to get fucked? Is because if the USMLE asks you for the mechanism via which MSSA goes to MRSA, students will see beta lactamase production and they choose it, and it's wrong because they see this answer so ubiquitously. The answer is altered penicillin binding protein. Okay, that's the mechanism via which MSSA goes to MRSA. And the reason we know that is because community staph already produces beta lactamase. As I mentioned, 90% already produce beta lactamase. So when you go from MSSA to MRSA, it has to be a different mechanism. Okay, so we treat MSSA with methicillin class drugs because they're sensitive to them, such as dicloxacillin, nafcillin, flucloxacillin. But then, of course, for MRSA, we give vancomycin most of the time. Lots of exceptions, lots of talking points, but those mechanisms are important. Conjugation of functional groups, I wrote as a general, just to kind of mold with the rest of these answer choices, but methylation, adenylation, acetylation, these are conjugations that can confer bacterial resistance to aminoglycoside antibiotics such as gentamicin. Okay, so that's pretty much it for this. Herpetic Whitlow, high yield, can be HSV 1 or 2. USMLE is not going to force you to choose OMG, HSV1 more commonly for herpes labialis, don't worry, but this is herpetic Whitlow. You treat with acyclovir, and if herpes is resistant to acyclovir, it's altered or absent viral thymidine kinase. That's it.